Hello, Mr. Smith. How are you doing today?
Good.
I'm Dr. Baggett. I'm one of the lung doctors. I believe you have some problems with your breathing. We'll examine you for that in a few minutes. So, are you feeling better today than yesterday or the same as yesterday? Is anything better? Before you start the physical exam of the respiratory system, you have to take a detailed history, especially of the symptoms for the respiratory system. That means shortness of breath, cough, sputum, hemoptysis, and chest pain. After that, a detailed family history, a personal history specifically for smoking, exposure to occupational dust. And when you start the physical exam, you start invariably by first holding the patient's hand and feeling for the pulse. May I feel your pulse? While you're feeling the pulse, you have to also do the count for the respiratory system or respiratory rate. Normal respiratory rate is about 10 to 16, 12 is normal, 20 is abnormal. And frequently, if the patient is gowned up, you will not be able to do the respiratory rate count. And then you have to request the patient to take off their gown. Before going to that, you have to look at the hands of the patient, look for any clubbing, cyanosis, any nicotine stains. If you don't mind, Mr. Smith, may you take off your gown, please?
Yes.
After the gown has been taken off, you first do inspection, and part of that inspection is the respiratory rate. So again, count the pulse so that the patient does not get conscious, and count the respiratory rate. And you don't have to ask the patient to take any deep breaths, just normal breathing, and you keep on counting for 1 minute. Again, normal respiratory rate is about 12 and 20 is abnormal. Once you have done that, you do the inspection of the respiratory system, and for inspection, you have to make sure that the patient is sitting in a symmetrical position. That means the shoes are off, feet are flat on the ground, hand are on the thighs, and then you look at the patient. So what are you looking for? You look for the trachea. It's central because both the sternocleidomastoid muscles, the sternal head of the sternocleidomastoid muscle, are equally prominent. The next thing that you look for is PMI, point of maximal impulse. That's where the heart is. It's in the mid-clavicular line in the fifth intercostal space. In healthy people, frequently the PMI may not be localized. The next step is to look for the expansion of the chest. The chest should be symmetrical, expanding well with breathing, and inspection is the most important part to decide which side of the chest or which lung is diseased. The diseased lung moves less, and the best way to appreciate reduced mobility of the chest is by inspection. So you do the inspection anteriorly. Beside looking at the chest, you look for the movement of the abdomen. Frequently there may not be enough movement, then you ask the patient, if you don't mind, could you turn your mouth to the left and take a breath in? And when you're looking at the abdomen, what you're trying to make sure is when the patient takes a deep breath in, the abdomen comes out. When the patient blows out, the abdomen goes in. If it's vice versa, that means there is diaphragm paralysis. Once you have looked at the chest anteriorly, you walk to the posterior side of the patient and repeat the whole process. Look for the symmetry, look for the expansion, look for the level of the shoulders. They are better appreciated posteriorly than anteriorly. Then on the back, again, you look in the infrascapular region to see if the chest is expanding and the spine is central and straight. Once you have done this, you take a step forward and look over the patient's shoulder, because what you're looking for is the movement of the clavicle, and the air going into the upper lobes makes the supraclavicular fossa full. Having said that, for the purpose of documentation, the chest is divided into a supraclavicular region, a clavicular region, infraclavicular region, mammary and inframammary anteriorly. Posteriorly, the regions are suprascapular, scapular, interscapular, infrascapular. And laterally, the regions would be, if you can keep your arm on your head, please. Axillary, infraaxillary. It's divided at the fifth rib. If you draw a horizontal line, it should come to the level of the nipple. That also marks the minor fissure, and that's the point where the major fissure meets the minor fissure. You can keep your arms down. Once the inspection is over, then we start palpation. When you palpate the patient, first thing that you do is you confirm the findings of inspection. So the major thing that you're looking for is the position of the mediastinum. Upper mediastinum can be localized by the position of the trachea. You take one finger, trace the trachea down into the suprasternal notch, and the trachea should be in the center. If you move your finger on both sides, it should go in equally. That's one way of doing things. The other way of doing things is you put two fingers out here on the sternal head of the clavicle, and then trace the finger down and make sure that the trachea is in the center of the two fingers. That tells you about the upper mediastinum. For the lower mediastinum, you have to take the palm of your hand, put it on the chest, and feel it. And feel for the PMI. Frequently, it is difficult to localize. If you can find it, with one finger, localize it, and then count where it is. How do you count the ribs? So, this is the sternum, this is the suprasternal notch, this is the manubrium angle, where the manubrium meets with the sternum. It's called the angle of Lewis or manubriosternal joint. The second rib joins with the manubrium and the sternum out here, and then you can count the ribs down: second, third, fourth, fifth. So once you have done that, the next thing is to confirm the movement of the chest. And how do you confirm that? You take both hands, put flat on the chest anteriorly, and look for movement. When you're doing this, the thumbs do not move apart, they stay in center. What you're looking for is the anterior-posterior movement of the hand. And then you come below the mammary region, put the flat of your hands on the chest with the thumbs in the center, and ask the person to take a deep breath in. And here is when you're looking for movement of the thumb apart. It moves about 1 to 2 inches apart. Then you go to the back and again do the same steps. You feel for the clavicles, and then you put your hands over the apical region and ask the patient to take deep breaths in and out. So out here the thumbs do not move apart. What you're looking for is the up and down movement of your hands. In a normal person, they should move symmetrically, equal distance. Then next step is infrascapular region for movement of the expansion of the chest. You put the flat of your hands on the chest, bring your thumbs in the center, and ask the person to take a deep breath. They should move apart equally from the spine. Some people would take a skin fold in between the thumbs and see the skin fold disappears when a person takes a deep breath in and out. Once you have done that, the next thing we do is we look for vocal fremitus. So how do you look for vocal fremitus? Before you start on the posterior part, you ask the patient to keep their hands on the shoulder, the other hand out to here. What this does is it takes the scapulae apart, and there is more space in the interscapular region to examine the patient. Then again, you go intercostal space by intercostal space, asking the patient to say blue moon. Some people will use the palm of the hand, some people will use the ulnar side of the hand. So, Mr. Smith, can you please say blue moon?
Blue moon.
Repeat it.
Blue moon. 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 Blue moon.
Okay, thank you. So you compare one side to the other, and what you're trying to find out is if the vocal fremitus is increased, normal, or reduced. Once you have done the back, you can do the same in the axillary and the infraaxillary regions on both sides. If you don't mind, can you keep your hands on the head and say blue moon?
Blue moon. Blue moon. Blue moon. Blue moon. Blue moon. Blue moon.
Thank you. Then you can keep your hands down, and then you go anteriorly and repeat the same vocal fremitus. First in the supraclavicular regions. Okay, say blue moon.
Blue moon. Blue moon. Blue moon. Blue moon. Blue moon.
On the right side,
Blue moon.
you go down in the mid-clavicular
Blue
line.
moon.
On the left side,
Blue moon.
you try to go outside the mid-clavicular line
Blue moon.
because the heart is located out there.
Blue moon. Blue moon.
And you compare both sides.
Blue moon. Blue moon.
Once you are done with the palpation, the next step is percussion. So in percussion, there is a pleximeter finger, there is a plexar finger, and the rest of the fingers have to be elevated from the skin. So anteriorly, when you start from the clavicle. On clavicle, you don't need the pleximeter finger. On clavicle, what you do is just stretch the skin on the medial 1/3 and tap with your plexar finger with movement on your wrist joint. When you tap, remember you have to bring your finger back. It should not be left on the clavicle like this. It has to come back. And you compare the two sides. Then you go intercostal space by intercostal space with the pleximeter finger in the intercostal space and the adjacent fingers of your hand lifted from the skin. And you percuss on the second phalanx with the tip of your plexar finger. On the right side, you go in the mid-clavicular line. On the left side, you go slightly outside the mid-clavicular line to avoid the heart. When you do percussion, you're looking for two things. One is what we call geographical percussion. One is what we call topographical percussion. Topographical percussion that means you're trying to assess the condition of the lung underlying the skin, whether it's collapsed or whether it's consolidated. The percussion note would be impaired. Geographical percussion is you try to localize the various organs in the body. So anteriorly, once you have done your percussion, you can do the similar procedure posteriorly. When you're standing posteriorly, first you try to percuss the supraclavicular region. You percuss at three positions. One is over the lateral end of the clavicle, one is over the lung, and then medially. So in between the three positions, it should be resonant. That tells you about the apical segment of the right upper lobe and the apical segment of the left upper lobe when you do it on the left side. In tuberculosis, this resonance was lost. This resonance actually is also called Kronig's isthmus. Then for percussion posteriorly, what you do is ask the patient to keep their hands on the shoulder and then go intercostal space by intercostal space. See, by keeping the hands on the shoulder, the scapulae have moved apart and there is more area where you can percuss easily. You do not percuss over the scapulae, you percuss in the interscapular region and the infrascapular region. And similarly, you can mark out the liver, and once you find the liver, then you can mark out the mobility of the diaphragm. The next step after this is auscultation. So on auscultation, you try and confirm all your findings of inspection, palpation, percussion. You use a stethoscope. The stethoscope has these earplugs, which are directed medially, anteriorly, and have to be kept in this direction so that they go into your ear canal properly. For respiratory system, we only use the diaphragm, not the bill. And if you're old like me, you want an electronic stethoscope so that it can upregulate the sounds. Auscultation again starts region by region. You compare the two sides and ask the patient to turn their head to the left side and open their mouth and take deep breath in and out. Slow, easy breaths. Then you auscultate in the axillary and the infraaxillary region. Ask the patient to keep the hand on the head and take deep breaths in and out. And you compare it with the other side. While you're examining the patient, you want to cause minimal discomfort to the patient. So you try to do all the steps anteriorly first and then go posteriorly. Once you have heard the breath sounds, then you do what is called vocal resonance. Vocal resonance is always the same as vocal fremitus. They look for the same things. So if the vocal resonance is increased, the vocal fremitus is increased. If the vocal fremitus is reduced, the vocal resonance is reduced. It's never opposite. You can ask the patient to say blue moon again, or you can ask the patient to say 1, 1, 1. Okay, if you can say 1, 1, 1, Mr. Smith.
1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1.
And you again compare the axillary and the infraaxillary region.
1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1.
If you suspect bronchial breath sound, then you do what we call whispering pectriloquy. So you ask the patient to speak as if they are whispering in your ear. Wah, wah. Can you say wah, wah, Mr. Smith? Wah, 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 wah. Thank you. So if bronchial breathing is present, the WP is much sharper, much clearer, as if the patient is speaking right into your ear. And if WP is positive, that means bronchial breath sounds are present. You repeat the whole process posteriorly. So if you can please keep your hands on your shoulder and take deep breaths in and out. Now can you say 1, 1, 1?
1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1.
And thank you. And as in the front, if you suspect bronchial breath sounds, you do whispering pectriloquy again. So that's a simple respiratory system exam, walking you through the 4 steps of inspection, palpation, percussion, auscultation. Then there are special scenarios, and I'll show you a couple of things out here. Suppose you're suspecting pleural effusion and you think that the patient has on one side decreased movement of the chest, has a percussion note which is dull, and an area where vocal fremitus was low and there were absent breath sounds. Then what you need to do is, what we are looking for is shifting dullness, because the fluid will shift due to gravity. So what you do is percuss in the mid-axillary line to where the note becomes dull. Then keep your finger out there and ask the patient to lie on the bed on the opposite side. Mr. Smith, if you can lie down, please. On your left arm. And after they have been lying on that side for some time, see, I have not removed my finger, I have kept my finger there. Then you percuss again, it should become resonant. And then again ask the patient to sit up to see if the dullness comes back. So for shifting dullness, there are 3 steps. First, you have to identify the area which is dull. Then you have to make the patient lie on the opposite side for about 20 seconds or 30 seconds. And if the fluid moves away, show resonance. Keep your finger out there, don't move it, and then ask the patient to sit up again and see if the dullness comes back. The other special situation is, this is a healthy patient who can do all these maneuvers which I'm asking him to do. If the patient is sick, what do? The patient is lying in bed. If you don't mind, Mr. Smith, can you lie down in bed? And the important part of lying in bed is, always remember, when the patient takes off their shirt or gown, to cover them up to the waist. For inspection, you first go to the foot end of the bed, look at the patient, then on the side of the patient, inspect the movement of the chest, and then go to the head end of the bed. And again, scan the chest to see if there are any abnormalities that you can observe. Palpation, percussion, and auscultation are the same. I want to point out another interesting feature. When you do the percussion, or when you examine the patient, you're supposed to stand on the right side. And you do the percussion, see, you start from the clavicle, then you put your pleximeter finger and the flexor finger, and then after the second or third intercostal space, it becomes very difficult to percuss further down. However, if you go to the left side of the patient and do the percussion, it is much easier. So all the physical exam has to be done from the right side, but percussion of the interior chest is easier if you stand on the left side of the patient. Thank you, Mr. Smith. Now you can put on your shirt. I appreciate all your help. Thank you.